Breathing, if you want to look at it up, it's called ventilator valley. You look at it down, please. And then you figure out your pressures. So that's the basics of swans. Now, here we use flow tracks most of the time. So, flow tracks are a relatively non-invasive type of monitoring that hooks up to an A-line. And so what's the basis of the flow track? So the basis of the flow track, I guess, is this. So if you put an A-line into somebody, tracing will sort of look like this with a dichrotic notch and up and down, and you'll get your systolic and diastolic, and it should be pretty consistent. In somebody that's intravascularly volume depleted, what you're going to see is variation with inspiration and expiration, because as you inspire, you have better venous return. When you exhale, you have lesser venous return, and you'll see an exaggeration of an up and down thing. Where like during one phase they look like this, during another phase they look like this, and that's called basically pulse pressure variation. And so if you have a pulse pressure variation of more than 10%, looking at an A-line, you're probably volume depleted. So what the flow track does, that reads out on like an instantaneous basis, and it calculates a number. So the numbers that you'll see in the flow track machine are usually, the main numbers you got to worry about are the SVV, the cardiac output, cardiac index, because cardiac index is more accurate because it's for body surface area. You can have a small person that's got a cardiac output of 4 that's adequate, and a big person where it's not very good. So cardiac output, cardiac index, and SVV. If you have an SVV less than 13%, you're euvolemic. You could have more than enough. If it gets lower, you could actually have too much volume on board. If it's greater than 13%, high is dry. That's how you remember it. So high is dry. So basically what you're doing is you're looking at a patient, you're looking at their blood pressure, you're looking at their cardiac output, or index, and you're looking at their SVV. And so what you do is, so if you have, a high cardiac output, / cardiac index, and they're hypotensive, and their SVV is lower normal, then you got your septic patient again, right? If your cardiac output, cardiac index is low, their SVV is low, and they're hypotensive, you got cardiogenic shock.
In the septic patient with the SVV, is the volume variation high or low?
Could be. It doesn't matter. If they have a high cardiac output and they're hypotensive, the SVV can vary.
Okay.
You know what I mean?
Yeah.
Now, if you start to see that the SVV is low and you volume loaded them a ton, then you know it's time to go for pressors, basically. Same thing. It's not very complicated. And then if you have, low cardiac output / index, high SVV, and a low blood pressure, and they're hypovolemic. So it's pretty much the same hemodynamic profiles. And we've actually had both of these in people, and they correlate pretty well. People that they're most difficult to correlate are probably people with pulmonary hypertension, because it's a different animal. But still, they correlate pretty well. Now, in order to get an accurate SVV, they have to be in a sinus rhythm. So that will obscure things. We're getting new ones that sort of can read through the AFib.
Can you still use it as a trending tool?
You can. Well, the important thing is, the point of this, these are all trending tools, because the absolute numbers have all these inbuilt errors. So I think it's really, all these things are basically used as a trending tool. Well, the one thing I didn't mention about was cardiac outputs and doing the SWAN, or how to do them. We talked about them. Well, cardiac outputs in this one are done often through what's called thermodilution. So you inject cold saline in at a proximal port, you see temperature change at the distal port. The less the temperature change, the higher the cardiac output. The greater the temperature change, the less the cardiac output. The things that will give you a falsely elevated cardiac output are not enough injectate, so you have a lower temperature change because it's not enough, or if you have tricuspid regurgitation. Things that will give you a higher cardiac output are things like too much, injected. So,
Steve,
yeah.
quick question. SVB, so that, from what I've read, it says, like, how accurate is it in patients that are not intubated?
Patients that are not intubated are probably more accurate, I would think, than patients that are intubated.
Because, like, when I was reading through the whole Edinburgh's life science thing,
Yeah.
it says, like, the patient has to be intubated for some reason. I can't remember off the top of my head.
I don't recall that either, so I don't want to give you a run misinformation.
Okay.
But I can't believe that would have a negative effect. But I've got to look, so I don't want to answer you incorrectly.
Okay.
The other thing that we tend to do is we supplement this with bedside echo, and we look at the IVC. So, I think when you combine this along with looking at the IVC, it helps you out quite a bit. So we go in the subcostal area, we look at the IVC. If the IVC is less than 1 centimeter, they're dry. If it's greater than 3, they probably have more than enough volume. And if it's somewhere in the middle, it's indeterminate. Now, it's a lot harder to read. This is why I'm saying this. It's a lot harder to read IVCs in ventilated patients. The reason being that your own positive pressure and the variation, the respiratory variation, really doesn't change that. That it may not change as much. In a spontaneously breathing patient, if your IVC changes by more than 36% between inspiration and expiration, you're dry. Looking at the internal jugular or the SVC, it's 18%. So they're easy numbers to remember.
So you measure both an inspiration and expiration?
Yeah, we'll do that sometimes.
Do you ever use it for for CHF patients and when you for diuresis?
Nah, not really. Never really have. If it's big, we diurese them. Or if it's big and they're septic, we cut back on the fluid and go up on the pressors. So what do we do with all these numbers? You know what I mean? So we already talked about what we do with these numbers. If you have a cardiogenic shock patient, you use inotropes. If you have a volume depleted patient, you give them volume. If you have a septic patient, you can give them volume up to a certain point and then add pressors. And then eventually add inotropes. Now where does that come into? So now I promise you we talk a little bit about oxygen delivery. And what's the rationale about doing certain things with oxygen delivery? Well, I don't think you can talk about oxygen delivery independent of hemodynamics. And so here's why. So the equation for oxygen delivery, right, is cardiac output times. Any of you guys can tell me? You should know by now. I don't mean to embarrass you. Because if you don't know it, she certainly does.
Hey!
She certainly does.
Oh, I do.
1 point something times the hemoglobin, 1.32.
So you were close. Hemoglobin
plus 1.34
times 1.34.
All right.
Times. Percent sat.
That's right. Percent sat.
You're right. Plus 0.03 times the PO2, right? Okay, so that's your number. So, so oxygen delivery is most dependent on cardiac output, right? You double your cardiac output, you double your oxygen delivery. Your hemoglobin is somewhat important. If you go from 8 to 10, you've gone up a certain percentage, right, like 20%. Your percent sat, not so much, but somewhat important. And your PO2 is really unimportant to a certain degree. Now you have to take this in the context of your pH, because your percent sat is dependent upon your pH, right? Remember the oxyhemoglobin association curve and things that shifted, right? So what shifts it to the left?
Acidosis. Right, or is that
No,
shifted to the right?
shifts to the right. Alkalosis, and these are board questions, let me tell you. Alkalosis, right? What else?
I meant alkalosis.
Yeah, you meant alkalosis. Hypothermia.
So is a shift to the right,
It's to the left.
to the left, a
And
drop
low,
in 2-3
2-3 DPG, right? And then the opposite shifts it to the right. So you can have a really good saturation, but in a severely alkalotic patient, that's not going to help you out very much. So you have to take those things into account. So this is assuming a relatively normal pH. So one of the things that drives me crazy is people always get upset about PO2s on ventilated patients, and they're relatively irrelevant. Now, dissolved oxygen may have some benefit in some of the brains and everything, in some of the head patients, but in the majority of patients, it's all about the percent SAT. And if they have a decent cardiac output and a decent hemoglobin and a decent percent SAT, then you have decent oxygen delivery. And the bottom line is that if you walk into a patient's room and their blood pressure is okay and they're making urine, you can go to the next room until you find the patient who's got a lousy blood pressure who's not making urine, and you better pay attention to them first, and then you can circle back to the other patients. And that's why we always, like, one of the first things I do when I walk in the room is I look at the Foley catheter, if they're in anymore. And they usually aren't critically ill patients, and what their blood pressure's been overnight. And so, like, critical indicators, those are the two most critical indicators. So you really have to pay attention to this. So if you have that patient that's in cardiogenic shock, you need to bring up that cardiac output. Because it doesn't matter what their hemoglobin is or what their percent SAT is, or it doesn't matter, or their 2-3 DPG, who cares? It's really contingent upon cardiac output. In the patient that is hypovolemic, here's what you're dealing with, is by increasing cardiac output, you're increasing oxygen delivery. How are you doing that? By volume loading the patient. In the patient that's septic, it's a whole different ballgame, right? So you go through this septic pathway that they gave you guys. That's like been revised a couple times. And they want you to hydrate the patients, right? Because they want them perfused. They want you to check that by looking at the lactic acid. And if that stuff doesn't work, right, then you talk about pressors. Okay. You talk about looking at the the CVP, which I think is a bunch of crap anyway. I don't really think they're useful. The SCVO2, right? And then if all else fails, add inotropes. Or you can add another pressor, right? So you get to your lever-fed. Plus minus vasopressin or epi. But not neo. Don't use neo because you don't want a vasoconstrict, a pure alpha vasoconstrictor. You want something that's got a little beta activity too. And then you can go down your pathway to dobutamine. And they tell you that you want to keep your SCVO2 at least 70%, right? Because what you want to do is you want to keep your AVO2 difference reasonably okay. So you know, look at your AVO2 difference. And what increases your AVO2 difference? What gives you a high AVO2 difference? See, this is where this all comes in.
Shunting? Is that what you mean?
Well, cardiogenic shock.
Oh.
Because your cardiac output is lousy, your oxygen delivery is lousy, and you extract as much as you can, right? And what gives you so high AVO2 difference? What's a low?
Sepsis.
And also and hypovolemia is going to do this too, right? And sepsis here, with the proposed mechanism being, like lack of oxygen uptake at the mitochondrial level, so your AVO2 difference stays small. The other things that do it are all your toxins, like your methemoglobin, right? Cyanide, carbon monoxide. Anything that keeps you from delivering oxygen to the tissue is going to diminish your AVO2 difference. So what you want to do is sort of fix your oxygen delivery. So how do you fix your oxygen delivery? Primarily by maintaining your cardiac output, and what's a good indication of your cardiac output is your mean arterial pressures, right? So this is the rationale behind keeping things a MAP greater than 65. Now the other thing I would tell you, that's why these are guidelines. You got to take that into the context of your patient. If your patient is chronically hypertensive, a MAP of 65 may not be the ideal number, because even at 65 they may be hypoperfusing. So if I see a patient with hypertension, then I ratchet up the pressors to get a better MAP, because they're going to go into renal failure if you don't do it, because they're not going to perfuse, because they don't have the autoregulation that they used to. Now, the other thing that people talk about, now the other thing that's interesting to me that'll stop any conversation with somebody talking about sepsis guidelines is when you start to get into SCVO2s, saying that you have a decreased AVO2 difference in a septic patient, often your mixed venous is quite high because you're not extracting oxygen. So your mixed venous comes back like 90, 95. You put your line in, you put in your SCVO2, you go, oh my God, I put it in the artery. But it's not in the artery, it's because you're not utilizing the oxygen at the mitochondrial level and your AVO2 difference diminishes. They can't tell you what to do with those patients because you can't target a 70 in somebody that's got a 95. As they get better, that number will actually come down because they'll start to utilize oxygen at the tissue level. But for the patient that is not appropriately hyperdynamic, you know, what is the response to somebody that's, for somebody that's septic? What should the normal physiologic response be? The normal physiologic response should be that they're tachycardic, right? That they have a high cardiac output. And sometimes you don't see that in patients. So we had a guy here with necrotizing fasciitis, okay? So we met him on Saturday, right? Mm-hmm. So we walk in the room on Saturday and the guy's on, you know, 30 mics of Levophed, vasopressin, and he's got a pressure of about 80 to 90. So we get a stat echo and we also look ourselves, and the guy's heart is barely moving, right? And his cardiac output and index are relatively okay though. So his cardiac output, I think at that point was about 4.8, his cardiac index was about 2.4, and 2.5 is okay. And we took a quick look and it was barely moving, and so we added dobutamine. And so as soon as we added the dobutamine, he basically came off the Levophed, because people that are septic get a septic cardiomyopathy. That even though their cardiac output is high, it's because one, the heart is dilated, so there's more blood in the chambers, and number two, what's the equation for cardiac output? Yeah, so they got a high heart rate, you know. And even though the stroke volume is percentage-wise diminished because they have an elevated amount of blood in the ventricle, the absolute amount is still relatively high. That's how you get the high cardiac outputs. It's not because the heart is contracting well, it's actually a cardiomyopathy. So we put them on that, and we saw that we could get them off the pressors within a relatively short period of time. And so the thought process is like, okay, so you take somebody that's super sick, maybe by making them relatively hyperdynamic and increasing their oxygen delivery by increasing their cardiac output, they will do better. And there's been studies that have shown that, there's studies that have refuted it, there's recently studies that have shown that again. So what happens in some of these people is they get what's called oxygen extraction that's really dependent upon oxygen delivery. Like you can keep giving them more and more oxygen, you give them more oxygen, and they'll extract more oxygen. Nobody knows if that's real or artifactual. But the theory is that if you can sort of make them more hyperdynamic, then they'll do better. And one of the things that you can do, one of the board questions I had was a guy comes in septic, he's a pacemaker dependent guy. He's having difficulty. What do? You turn up the pacemaker rate, you know what I mean, to increase his cardiac output. Hello? Yeah. Right, it'll be a few minutes. Or, you know, tell them to come up to the ICU and just wait out by the room 24, and I'll be with them in a few minutes. Or bye-bye. So anyway, nobody's sure if that's a valid thing to do or not. But I'll tell you what I think, and it's probably wrong, but that's okay, I don't really care. I think what happens is that if you take these subsets of patients, and we talked about this on the weekend a little bit, and you take somebody that's septic and not acting in a hyperdynamic way, and that you can give them medication or do something to manipulate their cardiac output that allows them to be more hyperdynamic, they will probably do better. And the reason is, I don't know if it's the chicken or the egg. Is it because you've increased their cardiac output and that you've made them more hyperdynamic, or is it because they're still capable of becoming hyperdynamic? In other words, if you take somebody in sepsis and put them on an inotrope because they don't have a very good cardiac output and they don't respond, that patient's going to do poorly. They've now gone from warm sepsis to cold sepsis. So sepsis will also eventually change its profile if the patient is going to die. And what will happen is that cardiac output that was high will come down, the SVR will go up, and they will look like cardiogenic shock, and they will not recover most of the time. The patient that you can give some inotropes to or manipulate them in a certain way to respond so that their cardiac output increases and their oxygen delivery increases, they will do better. But I think that shows that you've caught them earlier along the sepsis curve before they've progressed to the point where they're about to go into cold sepsis. So I don't know what the right answer is, but the practice that we do here is, you know, the cardiologists make fun of me because I use a lot of inotropes. I tell the cardiologists they don't know what they're doing, and they really don't know what they're doing when it comes to treating septic patients. Because they go, oh, they have a normal ventricle. Well, I don't really care if they have a normal ventricle. Get out of my room, and don't mess with my drips because you don't know what you're doing. Here's a paper, go read it. So, and I've actually had those conversations, and people can attest to that. So, I think it's worth trying. So, I mean, that's really, there's not a lot to talk about in terms of oxygen delivery if you know that equation. And then if you think about it in the context of the cardiac profile that you've established by either non-invasive or invasive means, you can really better the care of the patient, I think. And it's really quite simple after you've been doing it for, 20 to 25 years. Actually, I knew all this stuff by my second week of internship. But, I don't want to talk about that. No. It takes a while. You just have to get used to going through all this stuff.
So you're saying utilizing all these invasive measures, the end goal would be oxygen delivery?
Get them a good blood. Yes, thank you. And get a good blood pressure and make sure they're making urine. And that's really what it comes down to. Everything that we're doing is geared towards maintaining a reasonable perfusion pressure so that their organs function and they don't progress into multi-system organ failure. I mean, that's what it is. That's what it is, Mr. Science.
I think Sean's saying that he was right when he answered your question.
Not really. You're really worried about volume. He was wrong.
No, I was right. No, you said perfusion pressure. I was right.
Yeah.
I said pressure.
These boys. Dr. Stiegel, can I ask you a question a little off topic?
No.
With the, Dr. Stingone tells us all the time that if Levofed is working, just keep going up on it. Do you buy into that?
You know what? You can argue that either way. So the papers show that the addition of vasopressin will cause resolution of hypotension more quickly, but that the mortality doesn't change. The same thing is true of the use of stress dose steroids, but I do it. And I think it's a good thing to do.
But do you keep going up and up and up on the Levofed?
Nah, I hit a certain amount. If I look like I'm going to have to keep going up, I add the vasopressin. But neither one is right or wrong.
Right.
So when he's not here, I put his patients on vasopressin. When I'm not here, he takes mine off.
What about the use of albumin in septic patients and stuff?
Okay, what you need to do is look at the New England Journal from the last month and a half, and it's got it's really good. It's a 6 pages. You can actually stay awake for at least half of it. And it's about fluid resuscitation in critically ill patients.
Oh, it just came out?
Yeah, it just came out in the last couple of weeks. It's a real nice little review. And there really is not much use for colloid. But the bottom line is, and we've been talking about this in here, and I argue with the renal people, and I argue with
There's a
Hey.
podcast on Emma too. You still listening to that?
Yeah, how you doing? Yeah, what's up? Oh, well, thank you. Well, thank you very much. Yes, I am. All right? Oh, definitely. Oh, thank you so much. All right. All right. Okay. All right. Bye-bye. So, what was I talking about?
The fluid resuscitation.
Okay, so the fluid resuscitation article. The big thing is, like, I'll harp with these guys, and you've been in here, like, about creating hyperchloremic metabolic acidosis in these patients. And they talk a lot about that in that article. And so the change in fluid is really going to be more towards more physiologic solutions. And, like, they haven't listened to me for the last 2 or 3 years, you know what I mean? So your DKA patients, they should be resuscitated with a combination of saline and lactated ringers, so they don't get a hyperchloremic acidosis. You know, your septic patients, the same thing, physiologic solutions. Because everybody bangs them and bangs them and bangs them with chloride, and then they get a hyperchloremic metabolic acidosis, and there may be some downside to that. So that's one take-home point. The other take-home point was they were pushing this Voluvent stuff, right? So head-of-starches have been around for a long time. They cause a lot of coagulopathy, because the bigger head-of-starches were macromolecules, and they would attract, like, platelets and... Hey, what's up? Oh, okay. That's not good. What's her PCO2? Okay, and what's her guts? What's her bicarb? Yeah, she needs some fluid management there. All right. You know what, I'm in the middle of a lecture. I'll think about it in 5 minutes. All right, bye-bye. So anyway, so the macromolecules, they cause coagulopathy, they cause a lot of renal issues, so they made this smaller molecule, and that's, you know, what this stuff is. But in septic patients, there's an increased incidence of renal failure. So they're getting away from all that kind of stuff, the Voluvents, and they have very limited applications. As far as albumin, you know, you think about that in the pararenal patients, and that's the one class of patient where albumin is worth doing. It's, yeah, but you should read the article, and it's a good article.
We can get free access.
Yeah, and they have a copy of it already.
It's in my car.
Really?
Some candy.
Yeah.
From
It's under the dead bodies. So you're gonna have to dig under them. He like takes his, when he makes a mistake in the ICU, he just puts it in the car.
Go look in the trunk.
So, all right, I gotta get back to work.
Thank you, Dr. Siegel.
Thank you very much.